Good afternoon, and thank you for joining the RLS Foundation's webinar titled Cannabis and RLS. My name is Carla Diezenkowski, and I'm the Executive Director of the RLS Foundation. The surge in web-based programs during the COVID-19 health crisis has created a strain on the system. If you are experiencing technical difficulties, switch to the audio portion of the program as it uses less bandwidth, and be sure that your webcam is turned off. We thank you for attending and appreciate your patience and understanding with any technical difficulties that may arise during today's webinar presentation. Before we begin, please be aware that all attendees will remain on mute during this hour. We thank you for the questions submitted with your registration. Today's presenter, Jacqueline Bainbridge, will answer as many questions as time allows following the presentation. After the webinar, you will receive an email with a link to the webinar recording. Jackie Bainbridge serves as a clinical pharmacy specialist at the Anschutz Outpatient Pavilion Neurological Clinic, an extension of the neurology residency teaching program at the University of Colorado, Denver. She is also a professor in the Department of Neurology at the University School of Medicine and teaches at the Skaggs School of Pharmacy and Pharmaceutical Sciences, where she was awarded Professor of the Year for 3 years in a row. Jackie manages patients with multiple neurological states such as epilepsy, Parkinson's disease, multiple sclerosis, migraine, and restless leg syndrome. She is currently involved in cannabis research funded by the Colorado Department of Public Health and Environment. In her recent past, she has had projects funded by the NIH spanning subjects such as MS and neuroprotection trials in Parkinson's disease. Jackie also serves on the Foundation's Board of Directors and previously served as board chair. Jackie, thank you for your presentation. I invite you to begin.
Thank you so much, Carla, and the rest of your team for making this webinar possible. So we are going to talk about medical marijuana or medical cannabis for the use in restless leg syndrome. I will tell you, I just want to make the distinction now between marijuana and cannabis. So probably a decade ago, I gave a presentation to a lay group, and I was calling everything marijuana or medical marijuana. And the audience really had issue with the term marijuana. They would much rather hear about medical cannabis as opposed to marijuana, because marijuana, they feel, is more of a slang term, and that's where people are using the product for medicinal or not medicinal use, but also or for the high experience, so the recreational portion of the plant. So I will switch from saying marijuana to cannabis unless there is a study that refers specifically to marijuana, and then I will use that term. But just know that that is the distinction between people who use marijuana for recreational purposes or medical purposes. So thank you. Let's begin. These are my disclosures. I do have research funding from GW Pharmaceutics and the state of Colorado, CDPHE. Just as a brief agenda, we'll talk a little bit about an introduction, the history of marijuana components, different forms, some of the physiologic effects that people experience from these plant derivatives or products, components of the plant. We'll talk about conditions where there is evidence supporting the use of cannabis. We'll talk a little bit about research or lack of when we're speaking about restless leg syndrome. We'll talk about some of the risks and some of the federal laws. So with a brief introduction of restless leg syndrome, which I'll abbreviate as RLS, you know that it's a common condition, probably underdiagnosed, but it's very treatable. The symptoms really are consistent with an annoying sensation or a painful condition. And everyone's a little bit different, and it may drive back to what is actually causing the restless leg syndrome. You know, it's a neurologic condition. The prevalence is anywhere from 3 to 15% in the general population. We do know the incidence will increase with age. Slightly more common in women than men. Pregnancy is up to 35% of women, which accounts for that, more women than men. Diagnosis is really based on clinical features. There's no lab test or serum test that you can actually get that tells you that you have restless leg syndrome unless you have iron deficiency, and that may point to the clinical symptomatology of restless leg syndrome and being causation of those symptoms. I like this slide, description of RLS, because I've collected what many patients or clients talk about and describe their restless leg syndrome as either creepy crawling feelings, burning, the jimmy legs, gotta move, etc. So I like collecting people's descriptor of their RLS. Now, there are non-medical therapies that we use initially for the treatment of restless leg syndrome, and we also use these non-medical therapies with medical therapies if needed for the condition. The first thing that we try and have patients do is, or clients, is to really identify a trigger. So what makes their symptoms worse or more tolerable? So some potential non-medical therapies that really should be discussed with a healthcare provider are as follows. So we know good sleep hygiene is helpful in restless leg syndrome. Of course, that's part of the problem, is really kind of getting that managed so that you can get good sleep quality. We know that moderate physical activity is helpful in restless leg syndrome. Sometimes if you overdo it, that can make it worse in individual patients, not everyone, but some individual patients. We know that either hot or cold can make restless leg syndrome better. Sometimes stretching, rubbing, or pressure. Also some meditation or yoga, engaging your mind. Also acupuncture, and eliminate medications that can exacerbate your symptoms. Some cold preps can do that, some antidepressants, etc. And obviously, if you have iron deficiency anemia, that should be treated at the advice of your practitioner. Medical therapies that we have, again, this is not exhaustive because we're really focusing on cannabis today, but this is just providing a little bit of a background. First line therapy are the alpha-2 delta ligands. So we're talking about medications that are like gabapentin, pregabalin, or Horizon, which is gabapentin and acarbil, which is specifically approved for restless leg syndrome. Gabapentin and pregabalin are approved for many other conditions, such as seizure disorders. But we know it's very helpful in neuropathic pain and pain syndromes. We also can use the dopamine agonist. We no longer think that that's a good first line option because we know that they cause augmentation. So better to use other agents or keep the dopamine agonists in low dose, less frequent dosing intervals. We know that benzodiazepines can be helpful, but we know that they have a habitual pattern associated with them. Opioids such as methadone, also useful as a medical therapy for restless leg syndrome. Iron, if that's the issue that precipitates your restless leg syndrome or causes the restless leg syndrome. Levodopa, carbidopa, we know can be helpful, but again, you can see some issues or problems such as augmentation with levodopa, carbidopa. Other medical therapies that can be useful are cannabis and some of our anti-seizures, etc. So now let's talk a little bit about cannabis. Cannabis has been around for a very long time. We know that in the 19th century, marijuana was legally grown and utilized in the United States. Moving into the 20th century, we had the Marijuana Tax Act, which was in 1937, and that actually prohibited all use of cannabis on a federal level. In 1970, along came the Controlled Substance Act, which prohibited cannabis federally, and that actually moved marijuana or cannabis into a Schedule I arena. And we'll talk a little bit about Schedule I drugs in a few slides. Now in the 21st century, in 2014, the House of Representatives passed a bill prohibiting the DEA from using funds to arrest patients who were using cannabis medicinally in states where there was medical cannabis laws. And at present, many states either have decriminalized action and or legalized or medical and or recreational use of marijuana and or cannabis. So let's move our attention now to the plant. What do we know about the plant? It's very interesting and complex. We know that cannabis, when you talk just about the plant, contains more than 400 compounds. It's actually closer to 500. And over 100 cannabinoids have been isolated. We know that there are also parts of the plant that we don't know a lot about medicinal use, but people are studying the medicinal use of terpenes that are contained in the plant and actually give aroma to the plant. So it's the nose on that plant. To see if there are any medicinal uses of those particular chemical constituents found in the plant. So terpenes give the plant the nose when we talk about the plant material. We know that the cannabinoids and the terpenes are found throughout the plant material. So we're talking about the flower, the buds, the leaves, the stems, the stalks, etc. Now, when we talk about cannabis in general, usually we talk about THC and CBD because those are the two cannabinoids that are found most abundantly in the cannabis plant. We talk about indica and sativa. Indica, as my students have taught me, are more like Inda, the couch. Indica, when we talk about the type of cannabis, tends to be more sedating, hence Inda, the couch. Sativa tends to be more uplifting or more awakening. What we find now is mostly in Colorado, so we're in the wild, wild west here. When we look at the marijuana shops that are on many of our street corners, you find that you have a hybrid of indica and sativa. So sometimes it's really hard to get a pure indica or pure sativa. It's more that hybrid blend of the two. Now we know the first documented use of cannabis for medicinal purposes, you can actually find information back to 400 AD. And cannabis was actually mentioned in the Pharmacopoeia in 1850. So what is the difference between delta-9 tetrahydrocannabinol or THC and CBD? So THC, that particular component of the plant produces a euphoric feeling. Some people call that a psychoactive feeling. I tend to like using euphoric because it gives people that high feeling or that out of sorts kind of feeling for many people. The mechanism of action is it really is thought to be a partial CB1 agonist throughout the body. The beneficial effects of THC, we know, really can be helpful when patients are receiving chemotherapy in relationship to it causing nausea and vomiting. We know THC is helpful there. Also helps to promote appetite for people who need to gain weight and potentially some other medicinal or medical conditions. There are adverse effects, however, and we usually chunk them into short-term and long-term adverse effects. We know in the short term, THC actually increases your heart rate. So it can produce a panic type feeling in addition to giving you that objective bump in your blood pressure and heart rate. We know that it can cause memory loss, you can lose time, and you can have impaired cognition or coordination. We know that it can cause delusions and hallucinations, paranoia, and psychosis. I will say, since we've had legalization here in the state of Colorado, we do see emergency room visits. When we talk about what people see from smoking THC products is we actually see either the paranoia or psychosis, but you can also see nausea and vomiting, which is a hyperemesis syndrome. So it's really from habitual use of smoked THC. The edibles tend to cause more of the paranoia and psychosis, which leads to hospitalization from emergency room visits because people overdo or have a tendency to overdo the edible products because they don't wait long enough to take the next piece of the edible. When we talk about the adverse effects that are long-term, we do see an addictive component to THC, about 9% overall. We see in the adolescent group slightly more addiction. We do see that it diminishes some satisfaction in overall quality of life or life satisfaction. I will talk, if we get to this part under the risk section, that you may see a lower IQ with habitual use of THC. And again, the hyperemesis syndrome, which is a cyclical vomiting that really does not respond to antiemetics like we would use for other people who have nausea and vomiting. And interestingly enough, it appears that capsaicin cream rubbed on the abdomen may be helpful for the hyperemesis syndrome. So when we compare this with cannabidiol or CBD, this is the product or that very main constituent or one of the main constituents in the plant material, which produces a non-euphoric or non-psychotropic effect. So you don't get the high effect with CBD. The precise mechanism of action is unknown, but it may be an antagonist. So it balances out some of the effects that you get with THC. We know that with CBD, you don't get that bump in vital signs, so you don't get an increased heart rate with this particular product. So you don't see that significant neurologic effect. The mechanism of action of CBD is that it interacts potentially, and is what we think the mechanism of action is it interacts with our endocannabinoid system, which we have in our body that helps regulate homeostasis throughout the body. And the one endocannabinoid that is thought to be increased or used in the mechanism of action of CBD is anandamide. The adverse effects with CBD, we can see some sedation or somnolence. We can see that it decreases appetite. So this is going to become really important when we talk about one of the FDA-approved products, which is Epidiolex, which is CBD. It's a plant-derived CBD product, but it decreases appetite. So you have to be careful if that's given to children, which it's approved for with catastrophic epilepsy, that you make sure that the patient or the child is gaining weight because of that decreased appetite. You can also see some GI effect, nausea, some diarrhea, and fatigue. Now we have to compare what we see in the cannabis plant to what we have as industrialized hemp. So industrialized hemp, by federal law definition, is a plant that is of the genus cannabis, and it's any part of the plant that is growing or not that contains no more than 0.3% of THC, and that's the key with hemp products. So hemp, when we grow it, and there are many uses for hemp, but when it is grown, it's grown usually outside. These plants get very big as comparison to our cannabis plants. Our cannabis plants are really babied. They're much smaller. They're grown usually indoors. You control the CO2, the lighting. They're really baby because with those plants, you're really trying to increase the content of THC. And for hemp, it can be no more than 0.3% of THC. So when we look at federal laws, as I mentioned before, Schedule I products, so marijuana is considered by the DEA to be a Schedule I product under the Federal Controlled Substances Act. So that makes possession, use, sale, purchase, cultivation really illegal. So other drugs that are Schedule I would be products like heroin, ecstasy, mescaline or LSD, etc. So this also, because marijuana is still considered a Schedule I product, it really makes research very difficult. Very difficult to do. So what about our legal status of cannabis in the United States? And I find myself always updating this particular slide. So we do have 33 states where there is legal medical marijuana and the District of Columbia. 10 states have legal recreational marijuana and the District of Columbia. So I will say that there are only 3 states that really have no decriminalization or no legal or medical legislation surrounding cannabis or marijuana. Now this slide I tend to update on a regular basis as well. So the number of states that actually have various approved medical conditions. So you can see epilepsy and seizures. At the time that this was updated, there were 28 states that had legislation surrounding the use of cannabis for epilepsy or seizures. So if you look, migraine only had 5, Parkinson's disease 13, etc. Multiple sclerosis had 30 states. So it's interesting. This is where we see some of the legislation coming from, and where all of that information came from is listed on these next 2 slides. Now, the next 2 slides have not been updated because this is actually a picture. So you can see here, seizures, the number of approved states. At the time that this was written, there were 24 states. And at the time, the clinical evidence supporting the legislation using cannabis for seizures, it was felt that those studies were weak. There were small and RCT as randomized controlled trials, which That's usually the holy grail. That's where we get our best level of evidence to make medical decisions with, and also usually support products getting FDA approval. So we know that this has changed because we have Epidiolex, which is approved for the use of catastrophic seizures. But if you go down even muscle spasticity, so we're talking about conditions like multiple sclerosis, where there's considerable muscle spasticity, or even traumatic brain injury. At the time of this publication, there were moderate or large randomized controlled trials. So there was good or appropriate evidence to recommend using some of these products for that condition. And then you can look on this next page, Parkinson's at the time. There were survey data only in open label trials, which we don't really think that that's a lot of good evidence in the medical world in terms of giving us comfort in recommending a product, or in this case, cannabis, for that condition. So you can see that there aren't a lot of clinical trials that actually support the state's legislation that are actually approving medical cannabis for these conditions. So there's not a lot of clinical trials out there. That really is my lead-in to tell you we need more research. Forms of cannabis, it's really important to know how people are consuming the product. Is it a leaf product? So are they ingesting, are they smoking the product? Is it in a paper? Is it vaporized? Is it eaten? Is it an edible? Oil extracts, we see that nabiximols or Sativex. Sativex is actually used or approved in many countries, just not the United States. It's in clinical trials here. We know it's about a 1-to-1 THC CBD oral mucosal spray that is used for multiple sclerosis or spasticity. We know that there are single molecule preparations. I think I have a slide of these products coming up here soon. We know that there's a liquid formulation, Epidiolex, which is a purified CBD product that we'll talk about. It's FDA approved. The routes of administration, as I mentioned, it's really important to know how people are consuming these products. If you are smoking a product, we know that the bioavailability, that's what F is pretty variable. It's only about 10 to 25% for a smoked product, which is better than we see with the oral product. When you have a low bioavailability, that means that even within the same person, if they would take that oral product again, they may get a different response. And we actually do see that with the especially the oral products. The same person taking the same product 4 times, one of the 4 times they will not have the same response. So also we have to look and want to know how people are consuming the products, because we will know about the duration of action. So how long does it take for that product to actually work? A smoked product or a vaporized product is going to get into the system much quicker. An oral product, it's pretty far out there, and that's why people get into trouble with the oral products and end up in the emergency room with psychosis or cognitive issues. And the half-life varies between products as well. The way it's consumed, so either smoked, vaporized, or ingested. This next slide shows you some of the different preparations that you can actually extract from the plant material. Much of our research is actually done with that vaporizer, with that detachable balloon, or the dried flower buds on the upper top. Again, going back to how it's consumed, very, very important. So smoking it, you get your effects very quickly, even up to 10 minutes, and lasts about 2 to 3 hours. Vaporizing it, which is our preferred method, not putting it in oil like a vape pen, but using a vaporizer, which turns the product into a a poof of vapor. You see you get effects really quickly. It doesn't last that long. Now, when you eat the product, and we're talking mainly more CBD products, you actually go to an intermediate or a metabolite. So that's the 11-hydroxy THC, which is actually stronger than the regular THC, which can create problems. You don't get effects very quickly, as I've already mentioned, and it lasts for a longer period of time depending on the person. Now, when we look at cannabis activity at the CB1 receptor, so this is how we know what kind of an effect a person is going to have. So on the left-hand side of the screen, and I know this is pretty busy, there are the structures in the brain where cannabis will potentially work at. We see next to it the THC effect. So if you just take the amygdala in the brain, which is a deep structure, THC will create a paranoia or a panicked effect. Also, if you look at the nucleus accumbens, that's where you see a euphoric effect. Now, if you look to the right-hand side, you'll see that CBD counterbalances some of those effects. So just to the amygdala, follow it across, and you'll see that you have a decreased THC-induced anxiety when you add CBD to the THC. And then when you look at the nucleus accumbens, you see euphoria for THC, but then you see that it attenuated THC-induced euphoria. So you get less of the euphoria effect. So some of these effects we want, some of them we don't want, such as the euphoric effect for some potential people. It's also interesting to look at our dose response. We know about dosing for our for THC a little bit better than we do for CBD. We think of a low dose with CBD is less than 300 milligrams, but this is really inconsistent. It really varies between the product. We know that you see a typical response anywhere around 600 milligrams, but some of the studies actually you see a response as low as 25 milligrams. So I would caution people who are buying a CBD product, when you look at the label, I could really talk a lot about the label, but when you look at the label and it tells you how much to take, I would probably start with a quarter of that dose and then gradually go up just to see how your body responds. You know, now that I just jumped on that label bit, I will tell you that many of the products that are sold over the internet, even places in Colorado, I'm not talking about dispensaries, but we're talking about sold in gas stations or at the pharmacy, the label is not regulated. So what's on that label isn't necessarily all of the product that you're getting in that bottle. So as an example, we actually sent somebody in that purchased a CBD liquid product, paid a lot of money for it, almost $200. It was locked up in the back of the store. The person grabbed that bottle, continued to do grocery shopping. When they checked out, they were actually getting, they were asked for their driver's license, and the person asked, "Why are you asking me for my driver's license?" And the clerk had no idea why. The person went home, looked on the website, so I would encourage people to do this. Go to the company, look for a certificate of analysis, but then you also want to look and see exactly what's in that bottle. So within that bottle, it just said that it was a CBD product, but they're in a 30 ml bottle, there was actually about 70 milligrams of THC within that bottle. So it's not, the label is not all telling as to what is in that particular product. So buyer beware, and definitely do your homework on those particular products and go back, put the batch number in, and look for a certificate of analysis. We know that there are main short-term physiologic effects of THC. You know, you can have reddening of the eyes, dryness of the mouth, You can have sensation change in your skin. And we talked about an increased heart rate and your muscles relaxed. As I mentioned, there are FDA approved products. So Marinol was approved in 1985. This is a dronabinol product. It's synthetic THC. You know that it's a Schedule III by the DEA, and it's used for anorexia in patients with HIV/AIDS. It's also used for nausea and vomiting associated with cancer chemotherapy. Now, Epidiolex is a CBD product, so it's cannabidiol. It was approved by the FDA in 2018. Very different. This is a plant-derived, purified CBD product. So it's grown as the cannabis plant, and CBD is extracted. This is actually the first FDA-approved cannabinoid prescription drug product. We know it's approved for Lennox-Gastaut syndrome and Dravet syndrome, which are both catastrophic epilepsy conditions. We're in clinical trials now for many other conditions for FDA approval, hopefully. Sesamet is a nabilone product. It's a synthetic cannabinoid. So it was approved in 2006. It's a Schedule II by the DEA. And it is approved for nausea and vomiting related to chemotherapy-induced cancer, or nausea and vomiting for patients who have cancer. Sativex is almost a one-to-one THC and CBD oral mucosal spray. It's licensed for use in the UK and other countries, but not FDA approved, so not licensed in the United States. And it's used for multiple sclerosis-related spasticity. So I'm going to talk a little bit now about Epidiolex, which is that CBD product. And the reason I'm talking about this is there's not a lot of research on drug interactions that we see with cannabis products or side effects. And so really we have to look at those approved products and kind of extract what was seen in those clinical trials to try and make guesstimations or determinations if we're going to see drug-drug interactions with using a product that we get from a dispensary here in Colorado or products that are obtained over the internet. So that's why I'm bringing this information to you. I mentioned Epidiolex is the first FDA-approved plant-derived material. So it's a purified plant-derived material. We know exactly what's in this bottle. It is now descheduled. It started out as a DEA Schedule 5, and it is now descheduled, meaning it does not have a DEA designation, which makes access to the product a little bit easier. Now, this product is available only at a specialty pharmacy, and the reason for that is to control supply and demand. It's an oral solution. We know that there is a slight amount of THC in this particular product. I will tell you when patients are being tested for cannabinoids, the test is not specifically sensitive, most of the tests for THC and CBD. It just looks for some sort of cannabinoid. So I will tell you that patients can test positive for cannabinoids on this particular product, as you would see with many of the other products that you can obtain in our, obviously, dispensaries, but also in drugstores, etc. We do know with this particular product that it actually can increase your liver enzymes. So that's something that we watch for. It might go away on its own. We might have to decrease the dose of this medicine or other CBD type products that you may be consuming, or it might have to be discontinued. We also know if you use this product with some of one of our other seizure drugs that you'll have an increased rate of those liver function test abnormalities. I listed here the fact that there are drug-drug interactions that we're seeing in clinical trials. So again, this is something that we have to be cognizant about when people are attaining these products, even for in a dispensary or at Safeway or any of our any place in Colorado. Here are just some of the interactions that we did see in clinical trials. We know that Epidiolex plus one of our other seizure drugs, which is clobazam, will increase by threefold the plasma concentration of one of the active metabolites of clobazam, which is a pretty potent interaction. So we know that when you interface Epidiolex and clobazam, you actually have to decrease your clobazam dose by about 50% in patients so that they don't have more sedation or toxicity with the product, and so forth. That's just basically a reminder to talk about drug interactions. So what are we seeing specifically, and I'm trying to keep this just to RLS with the research side of things. We know that there is a lack of marijuana research, and this, again, is across the board, not just specific to RLS, because it's federally illegal. It's a Schedule I by the DEA. And then we know that, or what we have to rely on, again, is anecdotal reports, what we hear from our patients, and what has been researched from the limited data we have, and that research done in Europe. Now, private companies are beginning to conduct some marijuana-based research to gain better understanding of the product. One major problem, with current studies is that they don't use a standardized preparation. Again, because of that DEA Schedule I thing, it just makes research very difficult to do with these particular products. So what we see in the reports, even the research that we'll see in RLS, is that most of the studies are not objective, they're subjective. So, and it's not one specific product that people are using, it's when people come into clinic, hey, what are you using to treat your RLS? So those are the studies that are really hard to make any mindful decisions on, or be able to recommend a particular product for patients with a condition such as RLS. So when we talk about trying to make decisions about treatment of cannabis and RLS, we really kind of go back to what is seen in sleep and pain. And I've reported on that information in a prior webinar, so I'm not going to I'm not going to talk about those particular trials again. I can summarize them at the end of our slides. So what are we specifically seeing in RLS? Well, again, minimal, robust clinical evidence. Again, it's mostly anecdotal, looking at anxiolytic effects or anxiety reducing effects, sedation, or reduction for pain. There was, however, one study, which is actually a two-part study, which was cannabis for restless leg syndrome. This was the first report, so it was in 6 patients. And what they did find is that patients did have good response to cannabis. So the estimated percent of relief after cannabis use was 100%. Again, this is just 6 people. They were all receiving some type of treatment concurrently for their RLS. Now, the researcher or the principal investigator followed up and added additional patients to this data. So this is the second publication. And as you can see, people did, again, have a good response. However, it's kind of all over the board as to what type of product these people actually were using. So you can see that 70%, patient 3, 70% of a CBD product. Patient 11, it was 90% with CBD. So most of these people had just more of a THC type product than a CBD product. Now, I can tell you anecdotally, we do have a handful of patients at the university, and we've really seen an opposite effect. So we're seeing good results with CBD product with maybe a little bit of THC within that particular product. So again, we don't have very good objective data in RLS. I'm trying to get funding. We have a study all ready to go, but we're lacking the funds to do that particular study. So what are our remaining questions when we talk about RLS or using these products in sleep disorders overall? What should the dose be? What should be the formulation, the route of administration? What's really best to use in this patient population? What combination of cannabinoids? Should it be higher CBD? I think personally it should be, with maybe a low amount of THC or no THC. When you look at the sleep data, and this is, again, to make decisions on RLS, we have to go back to what's reported in the sleep literature. And basically what you see is THC is helpful getting people to sleep, but then people wake up oftentimes during the night. That also leads to a habitual use of a higher THC product because people are chasing their tail, and you gain a tolerance effect to the THC, so you kind of need more and more and more. So CBD is probably better at helping people overall for sleep as opposed to THC. Hopefully we'll get the answers that we need for this in the near future. There are risks associated with using these particular products. Now, I've reported this data well. I'm just going to go through it very quickly because I want to leave enough time for questions and answers. We do know that there is an addiction rate. You see adolescents addicted to marijuana as about the same amount as cocaine. You know, the problem with this is that it's brain development in adolescence because your frontal lobes, especially in boys, aren't developed until you're 25 or 26 years of age. So you have more impulsive behavior, and people really don't feel, or the adolescents don't feel satisfied. They want more and more and more. So it has to do with lack of frontal lobe development. In adolescents, we know dopamine's a feel-good neurotransmitter, so people like dopamine. And we know that many cannabis, many drugs of abuse increase dopamine as part of their mechanism in the brain. For me, it would be shoes on this slide because I love shoes and clothes and the whole fashion world. So not for food, and cocaine would not be my pleasurable increasing dopamine choice. I like this study. I talk a lot to high school kids, middle school kids, and we find that persistent users of cannabis, this is actually a longitudinal study, 1,000 individuals. If you look at the IQ of people who never used, and they took people with a 100 IQ, and then what happened to people who used this habitually over years and years and years, you found that their IQ decreased by 10 points. So maybe that's not so problematic in somebody who's at 160 IQ and they dumb down to 150, but now we're talking about going from 100 to 90, which is significant. And you think to yourself, why would you do that? Now, when I talk to adolescent-aged individuals, I also have to throw in what our older individuals are doing, or people of advanced age. This is data that I just pulled the marijuana piece out. These were people who were 55 and older that came into the emergency room, and they asked them, do you use any recreational drug? And you found that from the year 1995 to 2002, people using marijuana went from 300 to 1,700. So it's not just the adolescents that are increasing their marijuana use, but also patients of advanced age. Now, I think I'm going to turn this back over to Carla, our executive director, and she can advise me as to what questions have come in on the chat, or if we want to go through our frequently asked questions.
Well, thanks, Jackie. We have a lot of questions that people submitted with their registration, so we'll start there. Are there
Okay.
any examples of relief from RLS with the use of cannabis?
Yes, I tell you, basically you saw that data that was subjective data. It's not that great. You're just asking, I mean, it's something, but you're just asking patients what they've used and did it help. And then anecdotally, I can tell you that we are following a couple patients that we have been uh, looking at the products that they're using, kind of making some guidance recommendations. And they have been helped with a high product, maybe a little bit of THC, but people worry about the THC component because am I going to test positive? You know, and they don't want that stigma. So we need to find out exactly what ratio of product to recommend to people. But it does appear to be helpful in some individuals with RLS. Worth studying, which I want to do.
And we want you to do so that we can get those answers.
Yes.
Can THC be absorbed through the skin? If so, does it alter your mental state?
That's a great question. THC can be absorbed through the skin. It depends on what vehicle it's in or if it's a patch that's designed to be absorbed through the skin. If it's absorbed through the skin, you can test positive. You can have that slight euphoric effect. I would think that you would need to use a lot to get it to see an overwhelmingly cognitive effect, but it can happen, definitely can happen. But it depends. Not all of those products are useful, like some of the bath bombs and you know, some of that stuff really, it's not going to get in through the skin. It has to be a specific patch derived at getting something through the barrier of the skin. And what do you think about THC products or cannabinoids? They're highly lipophilic, right? They like to get in to the fat in the body and hang out there. But again, the skin's a good barrier defense mechanism. So it really takes a specific product to make it all its, you know, through the skin and into the system.
Okay. Could cannabis be a realistic alternative to opioids? I've exhausted all other treatments to my knowledge.
Well, research needs to really be done on that in several areas, not just RLS. I think that it can be. I can tell you anecdotally that at least one of our patients was on a higher dose of opioids, and that particular person is no longer on opioids, and they are on a high CBD oral product that is comes from a reputable manufacturer here in Colorado. So I do think it is an alternative. I can tell you that we're starting a back pain study that's funded by the state of Colorado, and we will look at tapering patients who are on an opioid for back pain, with decreasing their dose and trying to come off of the opioid, but that study has not commenced at this time. But I do think that it is possible, but I have to say, you have to make sure that you're getting a reputable product. And that can be difficult because oftentimes when you go to a dispensary or you get something online, you might be getting a product that's not going to be the same the next time you go to get it. So you really have to look at the certificate of analysis and make sure that you're looking at a reputable company.
Can you discuss cannabis as it relates to augmentation?
We don't know.
Okay.
Yeah, we don't know. Probably does it, we just don't know. Depends probably if it's a higher THC or higher CBD, because we do see that patients have that habitual component with THC, especially when you look at the sleep literature, that helps you fall asleep initially, but then just like alcohol, it wakes you up during the middle of the night, so your quality of sleep is not good. But it also seems like it drives people to want to smoke again, the THC component. So maybe we'll see something like a habitual pattern or an augmentation kind of picture, maybe. We just don't know, but it might be more so with THC than CBD, but we don't know. Sorry.
Okay, well, good to hear. No, that's a great question. Does smoking cannabis have a greater impact on relief of RLS symptoms than edibles?
Well, we know it gets into the system a little more reliably, but I would say not to smoke the product. I think it's probably better to use a vaporized product, but not a vape pen, like where you're putting it in, like especially vitamin E. We know that's the problem with using the vape pens and having lung problems. But a true vaporizer, like a volcanic vaporizer, is probably a better way to consume it. Now, I will tell you that patients are wanting more of the edibles. It might be better to use, just depending on the person, but more of an oral mucosal spray or a true vaporized product. That's the fastest way to get it into your system, is to smoke it or vaporize it. Sorry, go ahead.
Okay, and how long does that take when you smoke or vaporize it?
About 10 to 15 minutes to get into your system. Much longer for the oral products, right? And we know there's a high first pass metabolism, and it has variable absorption.
And so then an oral would take about an hour, hour and a half, or how long would that take?
Yeah, about 45 minutes. And everybody's going to be a little different, but about 45 minutes.
So that's why you said not to keep, if you're not feeling an effect, not to continue to ingest, shall we
Because
say.
that's when people get into a lot of trouble in terms of having to go to the emergency room because they have a psychosis.
Get those untoward side effects, huh?
Yes, yes.
All right. Next question. Does any scientific blind peer review report support the use of cannabis for RLS? And if so, is it recommended for CBD only?
Well, the only true report that we have in RLS is the ones that I showed you, that study 1, and then the addition of patients for study 2. And that was all over the board. That was mostly THC products, but that could be because that's all patients could get or thought to get. So we just don't know if it should be. I think it probably should be more of a higher CBD product and a lower THC product than high THC.
Okay. Has the use of cannabis been known to trigger RLS?
To the best of my knowledge, I do not think, I have not seen that. So I do not believe at this point that it can trigger RLS, but again, maybe we just don't know, and it's possible.
All right, so this will be your last question. Are you currently working on any cannabis research? Tell us what you're up to, Jackie.
Yes, I am up to a lot. We currently have a back pain study that's using a volcanic vaporizer. So it's the NIDA supply, or the government supply of cannabis. It's a plant, and we have a placebo plant material that people vaporize, and we're using that with, it's a crossover trial with oxycodone. We have a trial that I'm actually compounding an oral formulation of CBD high product for Parkinson's tremor. working on a trial of patients with Fragile X and behavioral issues. We've worked on a scleroderma trial, which was synthetic CBD. And then we are just approved for 2 new studies, one looking at back pain. Again, that will be a plant material that will come from the government. And we will be varying the CBD content and THC content and a placebo. Oh, I'm sorry, that is actually going to be an oral product now. So we will be compounding that particular product, but we're varying the amounts of THC and CBD. That's in back pain. And then we're approved for another trial that will be using the Epidiolex product in patients with autism and behavioral issues. So we're up to a lot in terms of cannabis research.
So when you go back to the Parkinson's and tremor study, is that
Yes.
something that would help with PLMs, PLMD? Would that be a possible, because we know that there's a lot of, about 80% of people with RLS have PLMD. So would we see any sort of use for that segment?
I think it's definitely a potential, but we haven't really looked at that in terms of
Well,
a main objective. But
that's not a question.
yeah,
Or a hypothesis. It'd be interesting to see how it would work. And then also, if you have RLS, because you have that, what about the other 20% who doesn't have that
right.
PLMD or PLMS? So, why are they different and how would the treatment apply to them? Just a thought.
I know. I love it. I love it.
Can you tell me, but we've been on the phones a lot lately?
Yes.
So, yes, we hear everyone. We've been keeping busy. But gosh, I thank you so much for your time today. This was a really great talk. We had about 315 people hop on and 100 throughout the talk. So I do want to remind everyone to go to the website and we'll have it loaded in the member portal section. So watch for that and we'll have the questions written up and have them in your night walkers coming up.
Well, and thank
The
you,
fall.
and thanks to your whole staff and all that you guys are doing.
All right, we appreciate that, and we appreciate all that you do. And then remind everyone to go to the education and events section of our website under get involved and sign up for our next webinars coming up. All right, well, everyone have a great afternoon.
Thank you.
Thank you.